Welcome back to Tech and EdTech, the show where we dig into the realities of learning and technology advancements. I'm your host, Sarah, and today we're going somewhere I've actually been genuinely excited to explore: healthcare simulation and workforce training. My guest today is Francisco Castelblanco. Francisco is a DMP, a registered nurse, and the MAHEC Director and Chair of Continuing Professional Development at the Mountain Area Education Center in Asheville, North Carolina. Francisco oversees more than 1,000 educational programs a year, reaching roughly 10,000 health professionals across the state. He's a cardiac nurse by training, an adjunct professor at UNC School of Nursing, and someone who's spent a career sitting at the intersection of clinical education and health equity. He's also been recognized for that work, including receiving the Martin Luther King Jr. Emerging Leader Award at MAHEC. There's a lot to get into today around simulation, modality choices, world training challenges, and how we build the healthcare pipeline earlier. Francisco, welcome to the show. It's so great to have you here today.
It is a pleasure to be here. Thank you very much.
Yes, absolutely. So, Francisco, clearly you wear a lot of hats. To start, can you tell us a little bit more about yourself? And when someone asks what you actually do at MAHEC, how you would describe it?
Sure, absolutely. So MAHEC is part of the North Carolina AHEC system, and the AHEC system is a nationwide program that started about 55 years ago in order to fund rural training, right, across the country. And the North Carolina system is one of the most developed ones in the country. And MAHEC is the largest single AHEC in the country. And so we're located here in Western North Carolina, in Asheville in particular. And we train residents, we train medical students, we have clinics, and my area is continuing professional development. And so we do a lot of programs for not only the learners, residents, medical students, nursing students, but also healthcare professionals. So current nurses, physicians, allied health, pharmacy professionals that are needing to continue their education and stay updated with the latest modalities, with the latest guidelines. And that is basically what 1,000 programs a year can constitute.
Amazing. Thank you for that. So, the center's mission is tied very closely to recruiting, training, retaining healthcare providers in Western North Carolina, as you mentioned. When or how do you think it was recognized that there was a gap in learning that, like, a lecture, online module, or clinical rotation couldn't fully address?
Yeah, absolutely. So I would say probably about 30-ish years ago, different healthcare organizations and even academic institutions recognized that PowerPoints and lectures were not enough, right? We've all been in those classrooms, in those settings where you have death by PowerPoint, where the provider or whoever is lecturing, and you'll retain anywhere between 25 and maybe even up to 40% of a lecture in a classroom setting. Online modules may even be less depending on how they're set up.
Mhm.
And so the idea behind simulation is, how do you reinforce not only the knowledge, but some of those very practical skills? So it has to do with kinesthetic learning, right? And like actually going through, because your brain will remember a little bit more than it would by doing something, right? By practicing something. And it develops that muscle memory, which is incredibly important in healthcare, right? And you learn so much more from mistakes. We all do, right? We all remember mistakes that we made. And so simulation really addresses that in a very safe environment, right? Simulation is about suspension of disbelief. And we make sure that these individuals are in a safe place, that we go over with them saying, it's going to be okay. Don't worry, this isn't anything that can harm you. But the simulations can get very realistic. And, you go into that fight or flight mode as a provider of like, okay, what do I do? What do I do? And so the simulation helps to train them and train that muscle memory and connect them with the knowledge and the practical hands on learning. And so simulation has been part of healthcare education now for a number of years, and it's continuing to evolve, right? It's no longer the simple mannequins and like pretending that like they're breathing or they're doing this or that. Mannequins now can blink, they can, have tears coming out of their eyes, their pupils can dilate, you can hear heart sounds, lung sounds, and they're continuing to evolve into other modalities such as virtual reality and different technology that is really something that is exciting, right? Because these younger learners grew up with this technology, right? And so they're used to it, they understand it, and they react to it, and they learn better.
Really important points that you brought up there, and I like how you frame that with the practice and, we learn better when we make mistakes, so I really love how you framed that, and it's amazing, and we'll dive into, how in-depth some of these simulations have gotten. And, in healthcare, some of these situations are very high stakes, right? So you're giving the students an opportunity to have a lower risk environment, but for some of those stakes that are very high, how would you decide that a scenario actually needs simulation time, where practicing in the real life would be too risky or rare or just not available?
Oh, absolutely. So we have curriculum design instructors who actually sit with, say, the residency director who comes to us and he says, "Okay, I want my surgery residents to have this kind of experience." And so we will sit with them and we will develop the type of simulation that best fits that group. And sometimes we have learners that are middle school, high school students that are coming in. And so, very different level that we also develop very specialized training for them so that they can get the best experience out of it. I'll give you one example in both. One for, say, surgery residents. When they have the ability to practice on different kinds of technology, right? So we have something called a laparoscopic mentor, which is a machine where they can come in and practice laparoscopic surgery. So they are holding the same equipment that they would be holding in an operating room, and they're looking through a screen, and the screen is simulating gallbladder surgery, for example. And so as they're moving their hands and manipulating what would be the extension of the equipment inside an individual's body, it is haptic. And haptic means that it is feeling very real. So it's pushing, it's gliding easier, it's harder, it's pushing against what it is showing you on the camera could be a different organ or a different part of the gallbladder. And so they're getting that feel, right? That sense of what it actually is like to do this surgery, but not on a real person, right? So they must be very first year, you know, couple of months into their surgery residency where they develop that skill, they develop what it feels like and understanding some of the implications of things that could happen because you can set up the lab mentor to be like, okay, this is going to happen now. And the resident doesn't see or know that. And then when they're in surgery, and they're actually doing the surgery on real patients, they've already had experience doing, right? They've already had that feel of what it feels like to move the equipment around, to tie sutures, right? Because they practice tying sutures in the same manner way before they touch a patient. And so it gives them that complete experience and gets them better at it without touching a patient yet. And then I'll give you another example. We have middle school students that are interested in health careers, and we bring them here in the summer and during the year, and we will do a pig heart dissection. So we have pig hearts that you can get, and the students are then taught a little bit about cardiovascular, and I make them jump up and down. And I love teaching. This is one of my favorite ones that I teach. I have them jump up and down and like, okay, you're going to measure your heartbeat now, and then you're going to sit You're going to relax. And then we're going to talk about, does anybody in your family have this kind of experience? So we talked about heart attacks. We talk about cardiac arrest. We talk about what to do in emergency situations. And meanwhile, there's a pig heart in front of them and they're wearing gloves and they're smelling this pig heart and looking at it. And they build up that excitement to touch these pig hearts and to get in there. And so then for the last part of the class, then we start talking about the different components of the heart. And I have them find, here's the valve, here's this artery, here's that artery. And pig hearts are very similar to human hearts. So it's a beautiful setup for it. And then they understand not only what the body does in terms of all of, the different functions of the heart, but they've touched it, they felt it. And then I talk about being a nurse in the OR. I talk about being a surgeon in the OR. Talk about being a cardiologist, about being a rehab technician. So then we're connecting careers.
Mhm.
And I say, hey, this is what these jobs can make. This is the type of schooling that you need. And so it puts that idea in their head. And once again, they go home, they're excited. It's like, oh, maybe I want to do this, maybe I want to do that. Some of them may never want to do anything like that. And so then they at least get an idea of it. Right. And so that's the exciting part about simulation.
Right, they come back with that knowledge, and it's good to know. I don't think I can do that for a living, even though, they might have an idea of what it's like to be a doctor or nurse or whatever, but then when they're in that scenario, they really get that feel, so that's amazing. Both of those examples were great, and how amazing and advanced technology is getting, how lifelike, these simulations are, so thank you so much for describing that, and it made me think of a couple of questions, and one you kind of answered, and it sounds like you customize it quite a bit for whether it's someone, like in middle school or high school, a first year on healthcare student, or, someone coming back for their continuing learning, that the design of the simulation is gonna change a little bit, or the way you approach it, certainly.
Yes, absolutely. And so one of the frameworks that they use is called Schoen's. And Schoen's framework is all about learning and adapting to the type of learning and make sure that the outcomes answer that so what. Yes, you were exposed to the information, you had an experience, but did it change the knowledge? Did it change that competence? And that is the ultimate goal, right? With education in general. And I think, making sure that we are adapting whatever type of scenario to the types of learners, and you develop objectives and you measure them and you try to make it, especially in simulation, as realistic as possible, right? But at the same time, maintaining that safety for the learner. And it's particularly important for the younger learners. We've had students who are in middle school delivering babies, right? Because we have the mannequins that deliver the babies. And there were a couple of objections to that, right? That, a parent wrote in, like, I didn't know that my son would be eh, delivering a baby, right? Or exposed
Sure.
to that. And, this is not a sex ed class that we teach. We're literally showing them, like, this is how a baby comes out, right? And this is what you would do as a nurse, as an OBGYN. And so you got to be careful, right, with
Yeah,
some of these. And,
sure.
and we've learned our lessons in that regard. But at the same time, we've also instilled in some of these people, like, that's what I want to do. Like, and
Yeah.
they're so excited about that. And, people are empowered to become something because now they have a better idea, right? They've seen it, they've experienced it. And in some cases, talking to some of the different healthcare professionals, because we do have physicians of all different specialties in our sim center who do help with education, even the education for middle school students, because they love teaching and they love inspiring that next generation. So that's I think one of the greatest parts of mayhec, in that we have so many learners and our faculty are just passionate about teaching and making sure that they're preparing students all across those pipelines and pathways, right? Going back to middle school, not just the residents, not just medical students, but all across that spectrum.
That's really great. It must feel really good to be in the room when you see that student have that moment of like, this is so cool. I want to do this. Like, this is what I want to do. Um, I want to go back to a couple things you brought up about, you still tying this back to learning objectives and competencies. So simulations, obviously, they're so realistic now. Is there a point that you think, and I think probably, I mean, generally my argument has been in most simulations that I talk about, the more real, the better. But do you think that's always true? Is there any point where it stops helping or can get in the way of learning?
So we make sure that before any simulation, whether it's with school students all the way up through residents or even fellows, right, who graduated residency, that we sit with them and we let them know, hey, this is a safe environment. We will put all these different kinds of situations in front of you, and you will be debriefed afterwards. And so making sure that they understand that their mental and emotional safety is a priority for us and that it is going to be okay, because you can quickly forget. And I'll give you one example of something that we do that our team developed here. We do codes, right? And code training for mock codes, meaning that
Mhm.
like a patient's heart went into a rhythm that is either not life sustaining or just completely stopped, right? They had a cardiac arrest and stopped. And so this is something that all hospitals, right, and health systems and all different kinds of sim centers do in terms of training. But we added a different component. We blindfold the lead for this mock code. In other words, we walk in and like say, hey, this is your patient, Mr. Smith. And, we are going to blindfold you now and let you know what is happening with Mr. Smith. Right. And so they get blindfolded and they're standing or sitting at the edge of the bed, right, in a chair or just standing right at the edge of the bed. And then we say, okay, Mr. Smith is not breathing.
Mm.
What would you like to do? And we walk them through that scenario. And at first, it starts slowly. It's like, okay, he's still not breathing. What would you suggest that we do? And being blindfolded gives you a whole different experience, because now you're going through in your brain, okay, what is that algorithm? What do I do? But you're not relying on the visual. You're having to rely on what you're hearing. And you're like, okay, put oxygen, give them oxygen. And then we don't say a whole lot more on purpose, right? We want them to start asking questions, right? And one of the main questions that we're looking for right in the very beginning is there a heartbeat, right? Can you feel a pulse? Right. And so to start guiding them into, and if they don't ask that right away, after about 2 or 3 minutes, we're like, okay, the patient is turning blue, right? Even though we're giving them oxygen, we haven't done anything more, right? And like they're going through all these things. It's like, well, what medication did they take? Did we do some kind of procedure or anything? And like we're answering all the questions, but really the patient's heart just went into this rhythm. And they're like, oh yeah, get a monitor on, start doing CPR. And so then, okay, here's Nurse Jackie. And Jackie is here for you. What would you like her to do? And he's like, okay, Nurse Jackie, start compressions, right? Because if their pulse isn't, you can't feel it, then you have to get that compression going so that that heart is now pumping blood to the rest of the body. And the most important part is the brain. And then we keep walking them through. But it is an incredible experience that, to your question, can be scary,
Mhm.
right? Because you're not quite sure what's happening and you're blindfolded. It's like a scary movie at times in one of, a challenging situation that happens in medicine, which is a code. So you've just made it even harder.
Yeah.
But the outcomes and the evaluations are spectacular, because then these students, and most of them are medicine residents, so internal medicine hospitalist program, they are the ones who are running codes in the hospital. And so then they are now going in much better prepared, right? And I mean, there's code teams in the hospital, but they always defer back to the residents to help run the codes because that's how they train them.
Mhm.
But it used to be kind of like sink or swim, and it was never pretty, never pretty. And so we made it an initiative of ours because we do have that internal medicine residency to make sure that these residents are trained much better and really develop that confidence in running these codes. And so it's exciting work. I love that the simulation center came up with that blindfolded code idea.
I
I hope
love
others
that.
do too.
What a great approach. That's really, really, really great example. Thank you for sharing. So I want to switch gears a little bit. You talked a little bit about modality, and so say you've decided on a scenario worthy of a simulation, but the next question is, what's the best tool for learning? So let's dive into how you would think about that. And the first one being VR, which I've talked about in a recent episode of this podcast as well. But VR is getting a lot of attention, and specifically in healthcare education and workforce training. In healthcare simulation today, where do you think VR earns its place, and where does a mannequin or a simple task trainer or some of the other things that you're doing work better? Or maybe there's just different scenarios for different tools.
No, absolutely. There's very different scenarios and different equipment. And a lot of it goes back to that initial meeting with whoever, right? Whether it's a school or whether it's a nursing program or residency program. And we ask them, what is the objective? What do you want them to walk away with? Right. And then what types of learners are there? Right. And understanding that there are different modalities that could achieve different results. So some are very much task oriented, meaning you got to develop a good competency for such and such, right? If you're tying sutures, and it's a matter of doing it not only using the physical trainers, and by physical trainers we have boxes. It's literally a box, and it has, what they would use in laparoscopic surgery, but it's very simple. It doesn't have the haptic part of it. And they practice tying sutures on fruit, right?
Mhm.
Like we will cut open an apple, we'll cut open a lime, we'll cut open any different types of skin on a fruit. And sometimes we even use um, pig pieces, right? In terms of we use pig hearts obviously for some of those, but they'll use different pig components that will also help to simulate different types of skin or different conditions. And so having them practice, that hands on can achieve that result. Now, if it is a simulation or something that they want to achieve that combines things, that is much more of the critical thinking component, then we pull in our curriculum designer. And the curriculum designer has a lot of ideas of like, okay, what about using this and making it a combination of different equipment that we have where you can use VR, right? And or you can actually have people in the room, physically in the room, and they're also talking to you, right? They're also answering some of the questions. And so it is a way of utilizing the really high tech components of VR, but also having that feel and that sound. And like, okay, you can touch them through the VR in theory, but you could also touch your patient. And the standardized patients that we have are the actors, right? And these are
Mhm.
the actors who
Yeah.
are like, yes, I'm having chest pain. And they're simulating it at the same time, and that part to me compounds the experience. It gives it just such a strong sense of reality because they're seeing it, they're hearing it, and they're touching, and so you have all of those components at the same time happening. And so I do think that the future of VR, the future of some of this technology is number one, using it in the right setting, right? Depending upon those
Yeah.
objectives, making sure that you're really asking the right questions before you develop anything, and then number two, constantly improving. We have to get better. Learners of this generation are learning very, very quicker than we did, right? They're developing these skills at a higher pace, and medicine needs them to, right? Patients are sicker, they're older, they
Yeah.
have so many more complex chronic conditions that, patient doesn't just come in with one thing. No, they have three or four, and they're 92 years old, right? And they're on 27 medicines, and you got to figure out all of these different things. So the scenarios are getting more complex on purpose because we want these students, particularly the residents and med students and nursing students, to develop those critical thinking skills. And so it's utilization of all of the tools at times, some in combination, some for different specific types of trainings and objectives. But it's really making sure that we design them for those learners and the objectives.
Yeah, I love that. How you're tying it back to the specific learner, how do they learn best and what's that goal? What's that objective? You're not just using a simulation to use it when, a piece of fruit will work just fine. You don't need the expensive equipment, like things like that are really great examples. So something that sets Mayhec apart from simulations that not only happen in your great state of the art center, but you bring it out to the field and communities. And it sounds like you're very well connected to what's going on in the community and how you're working together. Can you tell me a little bit about what changes when you're making that simulation happen or you're still trying to have that learning impact when you're on the road, you're in someone else's environment, what versus, having that dedicated center and equipment?
Sure, I can give you a couple of recent examples. One, we went out to a camp and we taught a wilderness first aid course, right? So it's in a camp setting, you're teaching wilderness first aid. So, what better setting can you do this in? And really making sure that, like, okay, this individual, and we bring a patient actor out there and a mannequin, we'll bring both, right? This individual just got stung by whatever. We don't know exactly what it is, but they're slowly going into respiratory distress, and or bam, what do you do, right? They collapse down on the ground. And so we've practiced with very hands-on scenarios, also individuals who had a leg injury, who broke a leg, who, maybe suffered some kind of, injury while like chopping wood with a chainsaw or whatever the scenario is. And then look around. What do you have out here that you can use to make a splint to carry this individual out, to be able to respond to them? Right, in those emergency situations, being in those settings is priceless. It is priceless. We have a campus here, and we're fortunate in that we have some woods around us, and so we will do that on campus to a certain extent. We practice bear attacks because we actually have bears that come through Asheville, our campus, all the time. Like, they'll walk through the parking lot, and they're, at the moment, pretty harmless. Like, they don't want to mess with humans.
Yeah.
They just walk through because right now the berries are not in yet. And so we've seen a few bears these past couple of weeks, and they're just looking for food, right? Because we're really close to the parkway. And so we have those simulations of what to do if a bear attack here on campus. If somebody gets, attacked by a bear. And so we do train individuals in those situations. And then a second example, this is something that we did a little while ago. We went out to a regional hospital for the Cherokee Nation, so a Native American tribe. It's about an hour and 15 minutes away. And we worked with them on how to improve a lot of different areas. So one of those were the respiratory emergencies that they have, in terms of like, how do you intubate, which is one of those skills that is really important when a person stops breathing, right? And you have to try to intubate. It is not an easy thing to do. right? And so we worked with them on, rapid sequence intubation is what it's called, and making sure that their staff were comfortable and that they were trained, that we trained an individual to do this training, right, for future individuals there. And then another thing that we did with them, because they had a challenge with codes, um, we went in and we did mock codes with them that were unannounced. In other words, we would show up one time at like 4 o'clock in the morning, one time at like 6 o'clock at night, during those times where you don't have everybody ready to go, right? Where you're not expecting it, and you call a code, and then you literally just essentially are watching what they do, how they do it, and then you debrief with them. It's like, okay, this is our suggestion, right? This is, what we think could have gone better. What do you think could have gone better? And we hear from them. And a lot of the times they make these improvements because they realize, like, hey, this is something that we can change the location of, the equipment here, or who responds to the code, or where's the respiratory therapist, right, at 4 o'clock in the morning. If the emergency medicine physician is not available at that moment because he's taking care of some other emergency, to intubate a patient. And so those are the things that I think are invaluable to some of these organizations and different settings, in that we can take it out to rural communities and make sure that individuals develop that training. And whenever we go out, one of our strong suggestions is that they develop a trainer, right? And so we do that train the trainer program with almost everything that we do, because you can buy a mannequin, right? And like, here's, $100,000 mannequin that can do all the things. But if you don't have somebody who is skilled in providing that education, who understands some of the components that we're talking about today in terms of learning modalities and communication and teamwork, all these different facets that go into it, when you're training with simulation equipment, then that mannequin is not going to be any more useful than anything else that they have, right? So that part is a key to taking training on the road.
Yeah, and it's very clear that you're focused solely on that objective and like really creating the most realistic scenarios possible for these learners, whether that's in your simulation center, out in the physical wild. You're creating all these files just like any like ER or any other scenario could come up. And, certainly you're referencing some specific rural examples, bear attack, other wilderness type of injuries, but those are still transferable skills even in the city, or you could come across, and then you would know how to, it sounds like, to adapt. And then you're talking a lot about the critical thinking, so it's not even necessarily like what it is, but the reaction to it and how you're thinking on your feet type of training.
Absolutely.
So, I want to talk a little bit about how you would give like advice to other facilities trying to launch something similar. So, say there's, for example, a institution that has the equipment, but they're not quite sure. They haven't figured out the implementation piece, how to launch the program. If you're advising one of these programs, what do you think? What capability would you tell them to build first?
Oh, the training the staff.
Yeah.
That is the most, I think that is our greatest asset in the sim center that we have. We have millions of dollars worth of equipment in there. But that equipment is pointless without the staff who know how to apply it, know how to apply the right types of modalities and the right types of equipment, and develop the right kind of scenarios so that the student outcomes and the learning outcomes are actually achieved. That is gold, right? And simulation educators, it is a great career. It is an excellent career. It pays really well. And you have the ability to work at some of the top centers across the country. And so they are invaluable. Training that staff is probably the greatest asset that we have, because you can get, the fancy mannequins and the different mentor tools and VR tools and everything, but if you don't have the right staff to be able to go forward, you're never going to be able to get the best student outcomes. And so we focus on training our staff and retaining our staff, probably is like our number one priority in the sim center.
So that's a really important point. And do you think there is an implementation cost, and maybe this is it, that organizations underestimate in the simulation-based training?
So the different components of your program, and we have the experience of starting it from scratch, right? When we started our sim program, we were developing a surgery residency, right? And so if you have a surgery residency program, where you're training these residents, you have to have a simulation center. That's part of the requirements, and so that's really the impetus why we started this. And then, I mean, from there, it just went forward of like, okay, we can do so many different simulations with so many different learners, not just surgery. But initially, we didn't know what equipment to buy, not buy, what they would use, not use, and we consulted with different simulation centers, we traveled around, and we bought most of the right equipment, but there were a couple of pieces that we didn't need, right? A couple of expensive um tools that we didn't have, and this equipment was not used that much, right? So my recommendation is to understand what are the goals of your program, whether you're an academic health center, or a surgery program, or even a nursing education center where it's primarily nursing. What are the valuable components of it? And once again, have to stress, it is the educators, it is those individuals that are doing that, because they can combine low modality um, trainers, right? Meaning they're not high fidelity mannequins or VR, and VR is even getting less expensive, and so you don't need all the bells and whistles, right? You just need the right program with the right people to meet those needs that you're trying to meet locally.
Yeah, and equipment is very expensive, and so there's this pressure a lot of institutions face with, "Well, we just invested, we gotta use it, we gotta make the best use out of it." So I like all that thoughtfulness in your approach, and, it could take a little bit time and, sharing your knowledge, and, it needs to be a community so folks can help. We all have the same mission of making sure these learners are ready for the workforce. I noticed, shifting gears a little bit, I noticed there seems to be some debate on debriefing. So let's shift from, the learner did the simulation and now it's time to really make sure the learning sticks, right? How to make that learning sticky from that experience. What are the elements of a post simulation debrief that can actually really change behavior and make it a little bit more impactful?
Yes, that's a great question. Have you ever watched yourself on video, right? If somebody records you doing something.
Yeah, it's like cringeworthy.
Yes, right? And so in these scenarios, right, where we do have cameras in all our sim rooms, right? And so we record the majority of simulations. And what we do is we build in time in that debrief so that we play usually a good part of that video, right? And like our educators are once again highly trained and like, okay, here's a good piece, here's a good piece, so they mark it as they're going along. And so when we play that back for them, and we set it up so that this isn't punitive, right? We want to learn, we want to figure out how we can do this better, and what you need more practice in, or what you think you can do better in the future, and so we set it up with that premise, and they watch the video, and then we ask them, so what do you think? What are your thoughts on that? And they come up with way more things than we would have come up with, right? Because it, as human beings, we're so highly critical of ourselves, and
Yeah.
especially watching
Right.
the video of it, and you're like, oh, I did that, oh, I could have done this or that, or like I forgot to do this.
Yeah.
And when you forget to do something, we had one doctor who forgot to tell the nurse to do chest compressions, and we didn't remind them. We didn't say anything. We just let the code go on, and no chest compressions were done during this code. And like the doctor was mortified, beside themselves. They're like, I cannot believe that. I cannot believe that. And like, we told them they weren't the first, right? That this has happened before, because it has. But I guarantee you that provider will never go into a code again and
Absolutely.
forget to like make sure that somebody's doing chest compressions, because it's such a basic component, but it's something that we take for granted, that like, oh no, somebody's doing it automatically. But if you didn't order it and like you don't say it, it's not happening. And then, we ask them to sometimes write it up, because then that reinforces things that they can do better, right? Like, what would you do differently next time? Like, we don't ask them to write their mistakes. We just say, what would you do differently?
Yeah.
So that it's framed in a positive way, because once again, that mental safety is so important for these learners. We want them to experience it, learn from it, and come back, right? And not be afraid of it, not be afraid of like, oh, I'm going to be videotaped this next time. And the stakes are, it's a mannequin. So, the patient's going to live essentially. But in real world scenarios, we want them to like remember, hey, I could do this better.
Yeah. Well, and that video almost it adds a little bit of nervousness probably too to but that's almost good, right? Because it brings another element that is a little bit more lifelike as well.
Absolutely.
And, you mentioned some of the things you're talking about bringing up kind of teamwork a little bit and that healthcare is very team-based. Nurses and many different specialists are working hand in hand with doctors, for examples, but the education piece can often be siloed. You're on your specific track to your program. So, what kind of gaps can be revealed during these simulations that, are getting missed out on for lectures or other single discipline trainings?
So part of the impetus for us to start doing the blind codes came from the goal that we saw overall with many different scenarios, that one of the objectives was, how do you improve communication, right? How do you make sure that there's communication among doctor to nurse, doctor to respiratory therapist, nurse to nurse aide? And it was a theme that came very clearly um, apparent to us, that we needed to include communication aspects in almost every kind of simulation that we were doing. And so that is something that we try to embed as a primary or secondary goal for everything, is understanding that healthcare now is so team based, and it has to be, because everybody's practicing up to their higher scope of practice, right? They have to. Healthcare is not easy. There's not enough of any role in healthcare, whether it's hospital or primary care settings. You have to do the max. And to be able to do the max, you have to be able to have good communication of like, okay, I'm going to do this, this, and that. I need you to do this, and making sure that like those teams are in close communication with each other. I'm going to give you one example of interprofessional education that I think is really, really like the future of how we do this, and how we do this a little bit better. We had scenarios where we had in the room a medical student, a nursing student, a social work student, and a pharmacy student. So there were four different disciplines in the room, and we had a standardized patient. So this was a live actor, and the scenarios had to do around substance use and care for this individual. And it was both in hospital settings and in outpatient primary care settings. And so you had the team develop, okay, this is our patient, this is what they're experiencing, kind of develop that plan beforehand. And who's going to say what? What are we going to ask them? And then they go in, They do the scenario, and then they step out of the room, and then they debrief amongst themselves. And we're obviously observing this piece here, seeing how they communicate, what they would go forward with, and then they go back into the room and they finish up the simulation. And that, to me, was one of the huge eye-opening things for these students, to be able to understand the value of all of those team members and what they brought to that patient care and ultimately patient outcome. And so, to me, that is part of the future of simulation and healthcare education in general, is more of the team-based care, because as healthcare continues to evolve, we're going to need a lot more of that, and making sure that they're not only learning together, but learning to work together well, and even bringing them back after they're all professionals practicing, to do some of these scenarios. So that's one of those outcomes that I think about. How do you improve that, and what do you look for that can really develop a higher level of competence?
Yeah, extremely important piece. Thank you so much for that example. So, Francisco, we've made it to the lightning round here. I'm just going to ask you a question and just a quick answer, whatever comes to mind, if that sounds okay.
Sure.
Great. Okay, so one simulation modality that gets overhyped.
That gets overhyped. I would say, depending on technology, right? It's the basics that really pull in technology. And so understanding and practicing those basics, communication is what comes to mind. Without that, any tool is not going to be as useful as you think it would be.
Great answer. Thanks. One low tech element that makes high tech simulations work better.
Debriefing, by far, making sure that those debriefs are honest and that they're learning opportunities.
One rural healthcare training challenge that works nationwide.
To me, it is developing better programs based upon the types of students, right? So, in other words, if you're training, or trying to teach middle school kids, high school kids versus fellows, it's making sure that that curriculum designer is integrated in developing those outcomes.
Wonderful. And is there a metric that you trust more than the number of people trained?
Oh, absolutely. So patient outcomes, right? And there's many different ways to track this, in health systems, in inpatient and outpatient settings, where is the patient better off, right? Are those, whatever it is that you're measuring, whether it's survival rate from a code or improved blood pressure numbers or diabetes, whatever it is that the goal was, that you tie it back to those patient outcomes, the most important thing that we can do.
Perfect. So, coming to a close, just a couple quick questions here. So, for the healthcare education leaders in our audience who are trying to improve their simulation based training this year, but they don't have $1 million budget. What do you think is the smartest move they can make first?
Without question, training your staff.
Training. Yeah.
And, you have that old adage of like, what if you train them and they leave? And I always think of, what a professional told me once, like, well, what if you don't train them and they stay?
Yeah.
Because these individuals are affecting so many lives. You train a medical student, a resident, think about how many patients they're going to take care of in their lifetime: nursing, respiratory, pharmacy, all of these areas, right? So if you can instill in them great habits and great skills and competencies, my goodness, incredible investment. But you got to train staff.
Great. So, finally, where can listeners learn more about Mayhec's work and the simulation training your team is doing?
Absolutely. So we're always happy to consult with anybody and share. We want organizations to do better. And so, our website is the best place to start, mayhec.net. And then if you look under, just you can put in the search bar Simulation Center, you'll see a bunch of the things that we're doing there. But I'm always happy if you wanted to reach out to myself or the Sim Center director. We are happy to get on the phone with you and just share things that have worked and things that haven't. We learn from each other, and ultimately, better patient outcomes is what we all want.
Absolutely. Well, it's such a pleasure chatting with you today, Francisco. Thank you so much for being here and sharing your insights and your amazing stories. What great knowledge. I really enjoyed our conversation today. So that's a wrap for today's episode of Tech and Ed Tech. If you found today's episode useful, please share it with some of your network who's building healthcare or other workforce training programs. And we'll see you next time on Tech and Ed Tech.